Everybody has a flyer in front of you. This is actually a PSA for something else from the Health and Welfare Council, but I think it's really, really worth taking a few minutes to just talk about it. One of the services that our agency provides is Virtual VITA, which is a tax preparation, basically it's tax preparation for people who make $55,000 or under in 2018. They qualify for free tax preparation. They do not need to go to any of the predatory kinds of companies that, you know, promise a loan and with high interest or anything like that. We basically have folks throughout Long Island. John, where's John? He's out there. John's actually helping out a little bit, but Virtual VITA is basically a way for folks to get their taxes done quickly, virtually. So our team, the Health and Welfare Council team, takes in the logistical information, and then a certified IRS preparer takes care of the actual processing. It eliminates the middleman or the middle person and helps folks get you know, it contributes to two things. It protects them from, like I said, predatory companies, and also helps people with, and I'm not as well versed because it's not my world, but their earned income tax credit, which is a big tool that one of the most, I think, statistically studied tools that helps lift folks out of poverty. So this is a really, really important service. It's going on from now until
April 15th.
April 15th, really, basically till tax day. And if everybody has a flyer there. Tommy Grace Melito in our office is the person running that whole program. So her contact information should be on there, and if it's not, I can give it to you. Or and you can just ask me, and I can give you.
What about Suffolk?
Suffolk's on there too. There's two different. Oh, that's weird. Wait, why are these? I'm sorry, we messed up the flyers. There is?
Yeah, there
Did you
are
pass
two.
out both? I only passed out one.
I only have Suffolk.
Okay, I just saw a pile in my folder and I still had the map. Okay. So can you guys share? Thank you. Listen, I'm the health equity expert. I'm not the tax person, okay? I can only handle so much.
Anyone have extra nasal?
Here.
So we can also virtually send it to
Yeah,
you
I'll
after the
send the
meeting.
flyer.
John can send out the flyers to you all through email. How about that? Okay? Sorry.
Emily, I have a question. Is it age specific or does it matter?
No. No. And in fact, what we found last year was we were looking, I think that we were focusing on seniors a lot, but what we found was a lot of young people, recent college graduates, are folks that really need that service. So, no, I think it's for an individual. But again, I'm not the expert, right? It's individual.
Yeah.
Or could it also be family?
I mean, if they're filing together. If they're filing together.
Then it could be, yeah.
500, then yes. If you're filing individually, 500. So it's all determined on the income based on who's filing.
No, because if they're filing together, right.
Right.
And also, if you follow us on social media, I know that everybody's posting about it on the Health and Welfare Council's Facebook page. So, good morning.
Good morning,
It's
how
nice
are
to see
you? Good to see you as well.
Okay, a couple of other things. So we sent out a save the date for the big conference, but I just want to give you a heads up, the conference date may get moved. So thank you for saving the date, but you're gonna have to save a different date. I apologize for that. Originally we were shooting for the end of March, but it's very possible because of a couple of different things. One of them is a keynote that we really want to get, so it may have to get moved. So just know that that date should stay on your calendar, but the likelihood is it's going to get moved. Okay?
Only later, you mean further down the calendar?
Not sooner,
Not
later.
sooner.
Yeah.
Thank
Yeah.
you.
I also wanted to just let you know that, and it's just very preliminary, but as you know, right now we're working under a no-cost extension from the state that is supposed to end at the end of April. After consulting with our partners in the Hudson Valley, who you also know is on this grant with us, but we are working as two different regions, we have made a request to the state for an additional extension. also no cost. We have not gotten any, we don't know that it's gonna happen. So we are planning and working as April as our end date, April 30th for the end of the grant, but there is a possibility, and as soon as we know, we will let you know that it will be, we're hoping, but we don't know. But I wanted to let you know that, because I think that's really important. Okay, so today is a really, really pivotal, exciting day in HEALI's existence. As you know, this has been a really big process for us from when it's been almost over a year, right, that we first met. I think our kickoff big summit was in March of last year, and many of you have been with us from the beginning. And one of the things that happened, because of all the work that everybody in this room has been doing, is we created these 3 work groups, and one of the work groups, the data work group, has been really helping us figure out what we need to do as we talk about adopting a technological infrastructure and working towards some kind of a care coordination model. What we realized was we really needed help identifying what we're going to do when we talk about data, right? So many of us have data, we collect data, we have to report data for the grants that we receive, but what are we doing collectively as a sector in terms of our identity as HEALI and what we provide and what we can do, and how do we show that if we don't have common talking points around data? Did I explain that well, Mike? Because you're nodding, yes.
Absolutely.
Good. So we really recognized that the real place where we needed help from a consultant was in that realm. So we started off with asking our data work group for recommendations, doing our own research. I spent a lot of time on the phone, on the computer researching folks, and we ultimately brought forward several different consultants that were asked to provide a proposal to us. And the data work group initially did the legwork of looking through their proposals and their ideas, and then together with the steering committee, who also put in a lot of extra time on this, everybody looked at those proposals, started to talk about it, and then we had a combined call back at the beginning of January where we had 2 basically finalists get on with the steering committee and the data work group, talk about who they are, what they do, and from that there was some conversation, questions were answered, and we followed up with references, and the steering committee ultimately decided to go with Intrepid Ascent. So we're really excited because I think this is going to be a crucial place in our work as an alliance, something we've been talking about, but I think for a lot of folks it maybe hasn't become as concrete maybe, and I think now we're getting to that place. So we had an initial kickoff call with Alex and some of the other Intrepid Ascent folks, and today I'm going to basically turn the wheel over to Alex to run the show so we can start doing the work and learn a little bit more about them and start to look at what we have to do as a team. Next week we are having meetings both with the steering committee and then the work group, data work group, at the Health and Welfare Council with the whole Intrepid Ascent team, and you guys are going to start having to do work soon, really soon. So it's all good work though. So I'm personally really excited. I feel like this was where we were moving towards in a very big way. I really ask that everybody be energized about this part of the work that we're doing, and if you are connected with other folks who aren't in the room today, we're going to be messaging a lot around this because we want to make sure that as many people are really engaged around this piece of our work. So you'll hear from us, but please share with your colleagues and mention to them as well. Okay? The floor is yours.
Well, I'll try to introduce myself while I plug this computer in because I've got this blue screen here. So, thank you. Please help me, John. Hi, everybody. My name's Alex Horowitz. I'm the Principal Technology Strategist with Intrepid Ascent, which is a consulting firm based in California, but with a presence here in New York as well. I live in Brooklyn, commuted from there today. I'm very excited to be here with all of you to have been selected for this contract with the collaborative. And as I'm going to talk about in my slides, and I'll go over and control them now, This is a extremely unique project nationally speaking. You, as a collaborative of community-based organizations, from my perspective, are attempting to build infrastructure and capacity to work with each other, to work with others outside your organizations, such as the healthcare system, to reach out to individuals from the ground up. This is not a top-down imposed care coordination or referral pilot or anything like that, where the healthcare system is telling you you need to do X in order to communicate with us, you need to do Y in order to share data. This is about, if I'm correct in interpreting everything that I've read so far in my conversations with Emily and others, this is about data sharing on your own terms. And to me, that's an extremely exciting concept. This is the type of thing that, I just came back from a conference, one of the largest health IT conferences in the country. It's called the Health Information Management Systems Society Conference. 100,000 people, 120,000 people, I think, this year in Orlando last week. The concept of sharing data with CBOs for most of the organizations there is barely beyond the concept of sending a referral from a hospital to a community-based housing organization. That's where their minds are right now. And this project is really bleeding edge from my perspective, and I'm just extremely excited to be working with all of you on it. So here's a quick agenda of the items that I wanted to cover today. The timing may go completely out the window as we start to go through this. I want to spend as much time in discussion as we possibly can today. In fact, I want this all to be a discussion. I don't want to stand up here and just talk at you the entire time. I encourage questions at any point as I'm going through, even in the part where I'm talking about the company a little bit. Please ask me questions, raise your hand, just shout it out. I'm happy to engage in discussion. It's much more comfortable of an environment for me to do that, so please do ask questions as I go through. So I am going to talk about Intrepid Ascent and some of our relevant work so far. I'm going to talk, and I'm also going to talk about the team that will be working with me on this project. It's not just me by myself. I'm going to talk about the national landscape as it stands from my perspective, from our perspective, around how community-based organizations are being integrated into the overall healthcare system. As I sort of preluded here, there are no projects like yours that I know about that are from the ground up, CBO engagement, where it's just CBOs working together to build capacity. Everything else has some sort of link to the healthcare system, but I do want to talk about a number of programs that bear some similarities that we can start to learn from as well. I want to talk about the specific contract that I have with the collaborative, how we're going to try to help your organizations come to consensus around technology infrastructure that makes sense, that's achievable, that achieves the goals that you want your organizations to get to, and that's actually useful for everybody. And then I want to start to have some discussion to see what you think about IT infrastructure that would be helpful. I know you all have gotten together with your data committee amongst each other and sort of talked about this before, but I think it would be good to have some discussion about what you think the best technologies, uses of technologies, or capabilities that would be best to enable for your organizations might be. So to get started, I'm going to talk about Intrepid Ascent a little bit. So we're like this. Wow, that is a terrible cord. Okay, I'll try not to step on it anymore. It's very exposed right there. So we're a strategic consulting firm focused around healthcare IT. But that was founded in January 2014. We just turned 5, which is a significant milestone, I think, for any small company. We have 11 full-time consultants and a network of subcontractors that we work with that are professionals in the field that work anywhere from 20 to 80% time with our firm as well. I myself have been in this field for 14 years now, working in healthcare IT previously with other consulting firms. I did a lot of work in California around building health information exchanges, what you call here in New York call RIOs, that involve sharing of data between healthcare organizations, which 15 years ago was a unique concept. Now it seems a lot more normal, but back then it was definitely new. I have a technology background, but our firm has individuals in it who are experienced in care integration, who are experienced in value-based payment models, quality improvement, working with community-based organizations, and policy. We do quite a bit of policy consulting as well around the rules and regulations for data sharing, enabling organizations to share data from a policy standpoint, not just from a technology standpoint. We are headquartered in Berkeley, California. That's where our home office is. I'm originally from California, but moved to New York 3 years ago. We have consultants in California, New York, and Texas. As I said, we focus in all of these different areas with our work today and have throughout the life of the company. So we are focused on guiding healthcare and community-based organizations through the adoption and use of information technology by not just by implementing technologies or trying to get folks to just implement technology for technology's sake, but as a means to working better with their clients, working better with each other, and toward overall improvement of the healthcare ecosystem, including social determinants of health and the services that you as community-based organizations provide. I think the statistic out there is that 80% of health is social health and is focused on the social determinants of health. You go to the doctor when you have a critical issue or the hospital, but your day-to-day life is improved when you're linked to social services, when you're linked to organizations that help with social determinants of health, family development, housing, tax assistance for income security, food security. These are all extremely important, and as I'm sure all of you are painfully aware, and as I've already stated, are oftentimes left out of care integration pilots, or sort of an afterthought. It's sort of, oh yeah, and we'll connect to the social services folks, but first we need to figure out our hospital integration policies and things like that, and this is not where this project is focused. So we have extensive experience working in public health. 90% of our clients are, actually probably about 85% of our clients are Medicaid organizations, Medicaid billing organizations. We are, so we're used to working in the safety net and with organizations that serve the safety net. We see ourselves as a very mission-driven organization in that regard. We like these types of projects. We like to see the impact of the work that we do in the community and to have direct impacts on the care that is delivered to individuals and families. We have a extremely transparent consulting approach. We like to work as a team with our clients. We like to be embedded. We like to have conversations. We don't like to try to do any kind of top-down consulting approach where we're just dropping a model in somewhere and trying to conform everybody to that model. We like to create new models with our clients, and I very much hope to be able to do that with this project. Let's go to the next slide. So this is a good slide that shows sort of our overall commitment. It is focused on healthcare. If I had more time, I would have created one for social services, but I hope through this project we can tweak this to make one for social services that I can use in future presentations. But we really are focused on these kind of three overarching areas. The expansion and adoption of healthcare IT, used to collect healthcare data and to standardize healthcare data. The sharing of that information between providers, individuals, communities, and all the organizations in between in a way that meets legal regulation, conforms to privacy of the individual and the preferences of individuals for their data sharing, individual control of data, and also provides for efficiency improvements in the healthcare system through that sharing of information. And then to use the information not just for efficiency's sake, but to strengthen care delivery, to advance the health and well-being of individuals and communities, and to enhance research, scientific knowledge, and innovation, which we all want to get to, but it requires all of this flow down to be there before we can get to that point. So we try to select projects that fall into one or more of these categories. I think that this project probably hits on every single one of these, although from the perspective of delivering social services to enhance the well-being of individuals, not necessarily traditional care delivery. So here's a couple of groupings of relevant projects that we're working on. We have a large number of them, and I didn't want to try to break them all out individually here, but we sort of have 4 areas of work that we're working on as a firm right now that are very relevant to this project that we can use to learn from, and some of which I'm going to talk about in a little bit more detail later in the presentation. One is the Whole Person Care Program in California. This is based on California's 1115 Medicaid waiver, which is the same type of waiver that your district program here in New York is based off of. California's version of that is called Whole Person Care. It started a little bit after district did. There are 25 pilots, district pilots, just like there are, I believe, 25, there are 25 PPSs or 24? 25, yeah, so 25 whole person care pilots, 25 PPSs. So 5 of the 25 California whole person care pilots are currently our clients. We help them with technology integration to share information among the various participants within the whole person care pilot. That includes hospital systems, provider offices, behavioral health organizations are especially prominent, and community-based organizations with a special focus on housing services. It's a big deal in California right now. There's a lot of focus on housing and the social agencies that are connected directly to housing. It's not every single community-based organization, and that's one of the differences between that program and this one, but there is a lot to do with connecting to housing in those pilots. We also do a lot of policy work around the sharing of behavioral health data as a result of those pilots, which has special rules and restrictions in California, similar but different to the special rules and restrictions for behavioral health data sharing here in New York State. We've been working on health information exchange since the very beginning, since our firm was founded, and as I said, I have for a decade prior to that. Right now, 2 of the 11 public California health information exchanges are our clients. These are similar to the RIOs here in New York. They're sort of these regional data sharing initiatives that are mostly focused on healthcare data, but as a result primarily of whole person care, are starting to focus more on social services data sharing, trying to find use cases, or it's a term that's hard to define. We talked about this.
I was like, what's a use case?
Right,
I don't know what
yeah.
that means.
Trying to find reasons to share social information such that it allows social services agencies and medical providers to be able to do their jobs better. That includes being able to calculate metrics based on social determinants of health, finding ways to share data that's regulated under HIPAA, healthcare data, with community-based organizations that might be interested in some of that information, like when was the last time this person went to the hospital, were they just discharged, when was their last medical appointment. These are important in many cases when you're trying to work with individuals who don't necessarily have a very regular or cadenced connection with the healthcare system. And these health information exchanges in California are thinking about ways that they can be the conduit for the sharing of that information. We have been working in California for many years with a number of federally qualified health centers, FQHCs. You have them here in New York. In California, they're more widespread and more directly responsible for the for healthcare delivery, ambulatory healthcare delivery to individuals who are on Medi-Cal or Medicaid. They are pretty ubiquitous. Almost every community has one. Some of them are massive in California. They also tend to form collaboratives of FQHCs. Some of them have over 60 different FQHCs all contracting together as one giant collaborative. We've worked with a number of those collaboratives and with FQHCs themselves to share data with each other, to share data with health information exchanges, and in many cases to pool their resources so that they can implement big data technology platforms so they can analyze their own data, calculate metrics that they have to report to the state more efficiently, and use that data that they calculate the metrics for to actually improve the quality of the care that they deliver. The reason I bring this up is that much like your organization, these FQHCs, and in fact all of these project types, deal with collaboratives of organizations. It's not just one client that we're trying to help in most cases. It's a number of different stakeholders that all want the same thing, but have slightly different needs. It's a tough area to work in. But it's where the most rewarding work, I think, happens, where you create new models that actually can be applied to other communities as opposed to just a one-off where, yeah, sure, I help that hospital, but they're completely different from every other hospital, so we're gonna have to kind of start over again. So we really enjoy working with collaboratives, have a lot of experience doing it, and my commitment to all of you is that I will balance our team will balance each of your needs and desires for technology equally, so that we can find solutions that work for everyone, not just for 2 or 3 organizations within the collaborative. And then finally, we've worked in the district program here in New York. We've worked with 6 of the 25 PPSs at one time or another here in New York, both upstate and downstate. We mostly worked on technology integration projects, a lot of times helping the PPSs work with their local RIOs and try to share information with them or create models for sharing of clinical data between PPSs and their partners. We also have a privacy and security practice within our firm, and we've done a lot of privacy and security work for organizations here, PPSs here in New York, and continue to do that for a couple of PPSs that are current clients today. I did it again. Any questions so far before I start talking about the team, about our previous work, or any of the, I know I'm throwing out a lot of terminology. I'm actually trying not to use acronyms as much as possible. But any questions so far on any of what I've said about the firm or any of our work?
How many of you in the room have done anything with, we have the 2 PPSs on Long Island. We have Suffolk Care Collaborative and Nassau Queens PPS. How many of you have gone to any of their, engaged with them at all, even prior to, I know you guys have, but prior to our grant starting? So some of you have? Okay. Okay, that's just to give you an idea.
Okay.
So.
My agency has.
Your agency
So
has.
I don't really know what the involvement is.
Okay.
Sure, and I'm going to talk a little bit more about DISRIP specifically in comparison to other national programs a little bit later in the presentation, so we can get into that a little bit more. So this is the team that we've brought for this project. You have myself, Wendy Jameson, who I believe is on the phone right now. Wendy's a subject matter expert with us who is very focused on quality improvement, care delivery models, and has for many years worked in the FQHC environment in California, as well as ran a collaborative of public hospitals in California called the Safety Net Institute for many years as its director. And so we're very happy to have her on the project to help understand the service delivery. It's not care delivery, it's service delivery models that your organizations have. Who are your clients? How are you serving them? And how do we translate those services and needs around those services into technology, whereas I'm sort of the main technology resource on the project, as well as the project lead. We have So-Kim Lim, who is a pharmacist by training, but has been working in health IT almost since day one, since I knew her. And she originally was focused very much on pharmacy data exchange, but quickly became a prominent individual in California around regulating and managing the various health information exchanges in the state. She's very focused on sharing of data within the healthcare ecosystem to improve care delivery models, so sort of a little bit of a crosswalk between myself and Wendy. She's also has a lot of experience with our firm doing large-scale data collection. So this is a large collaborative, and there's going to be a lot of information that we're going to have to collect very, very quickly. She's going to be the main person helping me to organize that information and to do a lot of the initial analysis. She's our primary analyst on this project, as well as a clinical consultant. Jennifer Kaufer with our firm is one of our managing consultants around healthcare improvement, which really sort of is is mass care delivery model redesign. She previously worked with a managed care payer organization in California, and we're very happy to have her as an advisor on this project. And Misha Vernon Wyatt, who is our project coordinator, you'll be getting emails probably from her for the most part, and working with her for scheduling and for sort of communications about the project primarily. And she's also going to be helping us as a project analyst. So that's it on the background of the firm. The next step here is to start to really talk about some of the national landscape for CBO integration, some of which I've already previewed. last chance for any questions about the firm or our experience.
This is not a shy group. I'm really amazed. Nobody has anything. No.
It's fine.
Okay.
Okay, there might be more discussion, I think, in this next section. Okay, so let's talk about the national landscape and how it's linked to the current project that we're going to get started on here. So, the holy grail right now in healthcare, even on the healthcare side, is to find a way to integrate the social determinants of health into the healthcare ecosystem from a data perspective. All of the work, or almost all of the work, around buzzwords like interoperability, data sharing, health information exchange, all those things, has been focused primarily on clinical data or claims data that is based on clinical services. That's where the money is. That's where there's a lot of organizations that have been really focusing on that. But it's also where even 10 years ago you had more standardization around that type of data, and so it seemed like the lower hanging fruit in the system. Social determinants of health data is not nearly as, there isn't a regulatory body that says this is how we're going to structure that information. As many of you know, there are a number of different assessments depending on what subfield you're in social determinants. There's a lot of academic study still going on in this. It's only recently become sort of accepted statistically, at least in the healthcare world, how important the social determinants of health are for the treatment of individuals. And so now there's this scramble to try to integrate this social determinants data into metrics calculation. How do we correlate it to treatment? How do we share it with each other? How do we first collect it and then share it with each other, going back to that slide from earlier with the steps. And so that's what the whole system is trying to achieve. And as I said before, this program is attacking that from the ground up, from your point of view, which I think is extremely valuable to getting getting everyone else to this point, and will give us some really great learnings. Let's see. So some of the things, some of the Medi-Cal waivers are focusing on this now. They're starting to talk about community-based organizations. I think, as you'll see in another future slide, the more recent we get in terms of when a Medicaid waiver was written and granted, the more they tend to talk about CBOs and social determinants of health in them. New York was an early, big Medicaid waiver program, but comparatively early in terms of your district program. There is work being done, obviously, this is partially connected to it, around CBOs, but some of the more recent pilots have, and waivers have a lot more focus on social determinants of health and trying to attack that as a primary recipient of funds, not necessarily sort of a secondary recipient of funds.
So you're saying in other states where they're kind of a little bit later to the party,
Yes.
that's more in the language than it was? Because DISRIP is now, Shirley, it's in year 4 now, right?
Yes.
Yeah.
5 starts April.
Yeah.
And the waiver was actually written even prior to that. The whole cycle, started even earlier, and you've had a few waivers that have just been awarded, and I'll talk about them a little bit in just a second. I do want to talk about one other thing. Foundations. So this is one example. The California Accountable Communities for Health is one, but a number of foundations are starting up really interesting projects around the sharing of information and social determinants. Have started to focus on it. The Robert Wood Johnson Foundation has a project that I'm going to talk about called DASH. The California Communities for Health project has been doing this in primarily rural areas of California for a couple of years now. And then there's a project I just learned about up in Rochester, I believe. So this group that Laura presented?
You guys remember
Gustin?
when Laura Gustin was here?
So the Monroe Systems Integration Pilot, I think is what it's called, SIP. That's what I would consider to be sort of a foundation-based approach to data sharing, and they're very focused on social determinants in addition to other things there. So this is sort of a consultancy slide about the sharing. Interesting. Why is it have that? Oh, I see. So this is a sort of a consultancy slide around what's the ideal data flow for addressing social determinants of health. And I'm showing this to you because it's a little bit idealized, but it provides a useful model for how the healthcare system tends to think of this. So the first step is to identify what, they're saying, okay, identify a need. What is the social determinant that we need to focus on? So there's a lot of this kind of narrow thought around, let's pick one, not pick all. Then they try to find a resource for addressing it. A resource could mean either an agency or a group of agencies, or a technology platform potentially to try to collect data on a particular social determinant of health. So once again, sort of starting narrow and then getting narrower, because you're talking about just a limited technology solution to address one data point. And then providing a service. So it's this very sort of funnel, it's clearly a funnel-based approach to addressing social determinants. I don't think that this works very well, because what you end up with, and this is something somebody said to me at HIMSS, is 1,000 different railroads with different gauges, basically trying to address social determinants. There's the housing track, there's the family services track, there's the education track, there's the legal assistance track. There, all these different things. And if you've got different data points, technology platforms, and ways to address each of these that isn't somehow unifying, it quickly becomes overwhelming for everybody involved, not just for the healthcare system, but I think for your organizations as well. Many of your organizations, I heard you say, aren't just in one area. Those of you that are, that's great, but many of you are not. You're doing, addressing sort of a broad range of social determinants. And, I've seen communities that have tried to implement technologies where, you've got 5 different screens that you're trying to juggle for referrals because every pathway is different. That's not where we want to end up. And so I'm only showing this to sort of throw stones at it. But this is where a lot of people's minds are.
And I just want to add to that, if you guys remember back in, when was our first collaborative brainstorming session? It was back in last April maybe, or May, and we talked about that, right? We talked about the fact that we didn't want to do this where we were just looking at this work as individual organizations, that would not help, it would not help us as a sector be sustainable, but it also wouldn't help the people that we serve, because we know none of them just have needs around one social determinant. So that doesn't make any sense. So that was something we really came to collectively really early on in our work. So I think you've got a group here that's on that page.
Great, that's excellent.
Yeah.
So here, and this is probably, once again, just sort of parroting back a little bit of things that you've already found out for yourselves, but this is just from our perspective, what are some of the challenges that you're facing that we're trying to address through this project? So you've all been working in this space for a very long time, here with this community, this community, but having a comprehensive picture of what services individuals are using or need access to, what social determinants are being addressed, is challenging. There's no one place you can go to say, okay, here's all the places that they're receiving help. There's not even one place that you can do that for medical services yet, although many of the RIOs are helping to do that here. Although, how many of your organizations have access to data, either from a portal or otherwise from one of the RIOs here in New York? 1, 2, yeah, 2 in this room. That's a problem.
So, just as an add-in, I now sit on, unbeknownst to me originally, a committee from NICE,
Okay.
where they're bringing together CBOs to think about accessing Shiny
That's great.
and having more people have. Now, I use those, first of all, NICE and Shiny, 2 of the worst acronyms ever known.
Shiny and nice.
And I honestly don't know what they mean other than that, but I think it is a shame that only 2 people raised their hands. But I'm a physician by training, I don't see patients anymore, but I know that even the Shiny on the medical side is not necessarily functioning. Transfer information between QEs, which are now what they call the RIOs, is not as seamless as one would want, nor is the information that's transferred necessarily usable.
Yes. Yes,
Sorry.
I can do I actually have a presentation partially about the use of the Shiny for provider organizations. That you're right, it's not easy. And for those of you who don't necessarily know that, does everybody know NICE and the Shiny, what those are?
Probably not.
Probably not. Okay, so NICE is the statewide and state person's here, so feel free to correct me if I misstate anything. But the NICE is sort of the regulatory organization that's a public-private partnership that regulates the RIOs, basically, and provides them grant fund. Their funding flows through NICE. And then the HEALI is a technology platform that NICE has deployed that allows all the RIOs to share data with each other. They could just do point-to-point sharing, but instead it's sort of this hub and spoke model where they all, it's like this central system where it will allow them to all share data with each other. And it's a great innovation. I actually know a few of the engineers who worked on it. It actually, it's one of those things where technically it works great, but the use case, this is where, once again, the use case for it didn't match very well with what was deployed, and so you've got a lot of frustration around the way that information is actually flowing when it gets down to the provider level, because they end up with basically getting all the information ever in the history of this person's life thrown at them when they try to look for it on there, and it's clinically, there are some issues with it. And I know that NICE is working on actually improving that, but yeah. So,
I have a question.
Oh, I'm sorry.
So there's probably a lot of us have a lot of thoughts that are going on, and it's really hard to articulate what they are, because there's so much lingo, and we basically, most of us are community-based organizations that are indirectly related to health. I'm on a regional executive committee that's related to behavioral health, because I worked with educationally related, because my organization represents families who have educational issues. Sidebar, one of the reasons that's such a problem on Long Island is because there are over 100 different school districts, and that's very impactful on Long Island, because each of those school districts have their own superintendent, and many different schools that have many directors of special education, and many policies that impact on, directly or indirectly, on kids' health that is acknowledged or not acknowledged. But, so that's how I got on this executive committee. And also I have family members. So anyway, I get this, I suppose because I'm on this, I get these emails as if I am a health organization. And so the way information comes is just so overwhelming and confusing. And so I get this information and I almost have to, it's like another language. I have to decipher this. Is this really meant to me? Does this apply to me? I get phone calls. I can help you. I want to collaborate with you. Is it really me you want to collaborate with? Is it because of this committee that I'm on? Is it because of this committee that I'm on? And it's a very confusing landscape out there. And for us, I think for me the biggest challenge is that the world out there doesn't really understand how connected education advocacy is to health, because of the way that school districts operate, especially on Long Island. Now, I know that California, in particular, has similar problems to Long Island.
Definitely.
And I don't know if they have all these different districts, because that really, nobody can make one swooping policy for Long Island. Every single district has to make a policy. And so I think people might have different concerns regarding their own, and I want it to be reflected in how you collect data, but I think that the landscape, the environmental landscape of Long Island really impacts on this and how we're going to manage that. Some of us do things do a lot of things for one region. Some of us do something very specific.
Right.
And just all of those things, and that's what's it's all like jumbling around. I don't have a specific question, but there's just a lot that's just jumbling around in my head.
So one of the things, I mean, Alex, I don't want to speak for you, but as we start to gather this, those are the things that you can tell,
Yeah.
you can report to Intrepid Assent when you're, filling out your questions and surveys. So that's the kind of information that they need to gather from us, because every single time, when I went and spoke at the Medicaid Redesign Public Comments Day, everything we are trying to communicate out is to indicate what makes us unique as Long Islanders and as a sector of nonprofit agencies who very much want to, improve what we do both for our agencies clearly and our engagement in whether it's value-based payment or whatever else comes our way, right? But also to build that infrastructure, because unlike our friends in New York City, we don't have that, right? We have these 2 counties that work separately. We have 125 school districts that work separately. You absolutely, but I think, and I think we've done a really good job, correct me if I'm wrong, of really staying away from the jargon as we've built this alliance, because you're right, that's not the world in which we work. But at some point we have to communicate with that world, right? So we have to figure out but as Alex said at the beginning, we have to figure out how we're going to do that on our terms so that we can build we already built the network, we've got it, right? People are engaged and excited about it, but we've got to figure out we can't keep ourselves in our own little bubbles on Long Island, because we know that's not sustainable either, right? So we have to figure out how we're going to do that. So I appreciate what you're saying, Linda, but I also think that will come. And I think you have to raise your hand and ask questions. If you don't know what a RIO is, if you don't know what a use case is, I don't know what that is. I'm not a healthcare expert. Those are the questions we have to just keep asking. Mike.
One thing HEALI might do, and I appreciate that, part of my job is, to try to translate that so that normal people, I'm a social worker too, but I'm in the technology side, so we can understand that. So that might be something that HEALI takes on as part of its website, the portal, and provides distill some of that information down.
Yep, that's a great idea.
Maybe a glossary to start with, and then other stuff as new things come out.
Okay, we have some of that actually, so we can definitely get that on. That's a great idea.
There are a few resources. I could show you a few resources that you can start with. That where people have attempted to do some indexing. So.
I mean, early on in this work, I don't know how many of you were on board. We did some of these trainings. Do you remember? And I think that part of what we found was that wasn't really relevant to where we were as a collective of nonprofits, right? So, but those webinars are all on the portal. So log on to the portal, they're there. And we do provide everything that the state sends out to us. We put that there. There are links to tons of VBP information and some of that lingo, but I think that the idea of a glossary and some very specific distillation of the language of this world, I think that that's a great idea. So we will work on that.
And just one more thing I want to say. In my world, we have regulations that basically that is everything is regulation based, and they're called the Part 200 regulations. And I must have gone to at least 5 trainings on those regulations before they became fluent. As a parent, fluent to me. So you've gone over this for you many, many times. All of these terms and how they fit together. So I think that it's I think embarrassing to ask each time what the term means. So it's good to just clarify the lingo every time you say it until it becomes more fluent for all of us.
And I'll try to define terms as I go through today as well. And I do want to say, just, and I'll get your question too. I just want to respond to one thing you said that, and build on something that you said, that there's no, so I would be, I'm not going to say or promise that we're going to solve through this assessment effort all of the issues that your organizations address. I mean, that's a huge, huge mantle. But we will solve a small number, or find a way to solve a small number of them and do it well in a scalable way, meaning that we can build that out to encompass other uses of the technology that are relevant as we go on. I mean, that's the idea, to put something in place that does the job well, that can be built out, instead of something that's purpose-built to only do one job and do it well but not be able to be expanded, or to try to boil the ocean, so to speak, and do everything at once and nothing is really that great. That's really not the approach that I'm going to be taking. So I appreciate what you said, that this is a complex environment. You all are addressing a lot of different issues here, and I'm going to be learning a lot about this as well, and I really look forward to that. And yeah, it's going to be a real journey, but looking forward to starting it. And you have a strong group here of individuals that are able to meet and convene to try to address these things, which is a lot more than most communities have, where they don't have this type of convening to be able to even surface these issues for consideration or to adopt technology.
A written glossary would be helpful.
Yep, I wrote that down.
Yeah, for you.
Yep.
Let's see, so in terms of challenges for your organizations, I think we went over, that was actually a good build on what I was going to say. We really, I think, surfaced a lot of what the challenges are. And you're being asked, I think the last thing that I'll say, and you mentioned this, Emily, as well, you're being asked to start thinking about participating in value-based payment, which I know is a totally dense term, and I don't want to try to unpack it all here. Suffice to say, there's a lot that can be done and that probably needs to be done collectively before you're ready to engage in value-based contracting or to start doing anything like that. And getting that foundational work completed, which is what I'm hearing this group is really trying to focus on, is extremely wise. Otherwise, you're going to get into a value-based contract and then, lose your shirt on it, or you're going to, completely, it's not going to be a good experience if you're not ready to, don't have the infrastructure to engage in value-based contracting. It's also better to engage in value-based contracting collectively instead of independently. And so, as a collective set of organizations, building infrastructure together is always a good step if that's the eventual future pie in the sky, not necessarily pie in the sky again, it's sooner than that, but still future goal.
That's the state's intention of the grant,
Exactly.
was to help us do that, and to figure out how and that's what we've been working on all along, so, but it's not easy, and just to speak to what you were saying before, Linda, I am not, and I've been doing this as, I'm the point person on bringing all of us together, but I am by no means an expert. I read about it and I try to educate myself, but that doesn't make me an expert in any of it, and I'm learning too. So it's helpful to know what we haven't made clear to this point, and you're right, it's repetitive and it's not language that's familiar to any of us. But again, when we think about what our goal is as this collective of nonprofit agencies, is how are we going to define how we want to engage in that world that is now saying to us, come participate. That's what we're trying to figure out. So there isn't I don't think it's black and white at this point. I think it's quite gray, quite frankly.
You have a question?
I have a question about, it sort of has to do with bullet 3 and 4. And I'm wondering, as we think about the community-based organizations that are around this table, I love the 3, the patchwork of data management and reporting systems that lack interoperability. I'm imagining that many of you have reporting systems that actually either report to a county or a state that aren't held, right? I have to report to a state agency, but it's not held, and I have data to do with that. And so I'm wondering, what level, and when we think about HEALI, we're really thinking about not involving those sort of other state agencies and county agencies, which we are already collecting data and reporting to separately than value-based. At what point does the rest of the state government start to think about value-based payments, or how that's then affecting their contracts and infrastructure?
So you mean like the counties, for example?
I'm thinking about, like, I have a contract with the Council for Children and Family, and I have data reporting in a separate data system that I report to on them. And if I want to go into value-based payment, I'm going to have a separate data system that I'm reporting. So I'm going to have multiple data, and many people already have multiple data systems. If you might be getting, you know, Office of Disability, I can't even think about it. You might be getting state ed money, and then you also might be getting CSF money, and then you have two different reporting and data collection. Is there
Right.
any movement on the state?
Well, yeah, and it's especially hard, I think, with community-based organizations that are not Medicaid billing, as you are not.
Our tier ones.
Because in the medical world, the value-based payment contracts are usually based around metrics and reporting that are tied to known standards for calculating those metrics, like HEDIS is an example, for those of you who know what that is. But it's basically a whole methodology for establishing you know, how are you doing at keeping people out of the ER, you know, those types of things.
I mean, it's another word for compliance.
Right.
It's a different kind of compliance.
Right.
Where you might have a state contract that's not health that says, you know, you have to report all this information on each individual that you serve, and
Right.
that's your compliance measure. So it's,
Right.
it's a different way of compliance, but it would be nice for different departments to align. Compliance.
Right, because with community-based organizations, like you're saying, they're all what we would call custom metrics. They're not based on an existing standard, partially because there isn't a very standard, you know, social determinants of health kind of mechanism for calculating those types of things, but also because that whole payment stream in New York for social services has been disconnected from the healthcare system for a long time. Even in other states like California, where you got a lot of value-based payment, they're still not fully aligned, but they're close. It's closer in California, for instance.
Okay, so there has
So,
been movement towards.
Yes, and I think that's super good feedback for the state, is that they should probably focus on aligning those payment mechanisms if they're expecting community-based organizations to contract under value-based payment, then they should align the data standards with the value-based payment data standards. And I can stand up on a soapbox and say that. I'm not going to be able to make it happen. But what I will say about infrastructure planning as we're going through this process is that we want to keep, it's hard to keep your eye on these three things, but we want to keep an eye on we want to know what your current systems are, even if they're for things like reporting on the contract that you just stated. We want to know what you've got.
Right.
Because we want to be able to, certainly don't want to make use of that system more difficult, but we want to make sure anything that we put into place either builds off of or works well with your existing system. So we're not asking people to rip and replace, you know, all their stuff. And then the other thing is we want to keep our eye towards what can we start to implement systems that are standards based that help your organizations be able to work with external partners like the healthcare system or like the state if they ever decide to move towards a value-based payment model for CBOs, so that you're ready to do that. And we're a very standards-based, I should have said it earlier, it might have been on the slide. Our firm is very standards-based. We're not about implementing one-off technology solutions. We want to conform to standards because they're scalable, because they aren't one-off solutions. They're not custom. Sometimes you have to customize, but we're really going to be keep an eye on standards for this project.
And just remember that we're talking about where we are now. We're not, we're talking about where we are now and and looking at where we are now and where we need to go together. So, we have to be very mindful not to get out in front of our own skis also, right? So you're not expected to be an expert in all of this yet, right? Or maybe never. We don't know. We don't know what's going to happen. So that's the other piece. We don't know what post-district, how this will all look yet. There's talk about what potentially is coming, but we don't know exactly yet what it's gonna all look like, so.
So what's the time frame? Because like I'm just thinking of my own agency. I have so many different contracts, and they all have different outcome measures. So and so just thinking of meshing with everybody else who has either has multiple contracts. So are we thinking that are we thinking 5 years? Are we like, what are we thinking? Do we have any time? I know this grant is only a year, so are we like thinking getting started,
I mean, we have a lot of unknowns, right? We
Yeah.
don't know what's gonna happen once the planning grant ends, and ideally, we're gonna have this model and this infrastructure idea and have all this plan in the final report that we give to the state. We don't know what's coming after that in terms of funding to be able to implement whatever plan we come up with. We don't know yet.
I think one thing, and not to be sort of not to be cynical at all, but just to sort of look at past experience. So the district program was intended to move New York State in the direction of value-based payment. I mean, that's the purpose of
Right.
the purpose of district. And I think that we can all agree that there were certain goals set for how much of how much of contracting we're going to move to value-based payment, and the district program did not get all the way to its goal of being able to transform the state's value-based payment mechanisms as much as they wanted to. Now, it certainly moved the needle, but not as much as was intended. It's very, very challenging, and I think the healthcare system in New York State is particularly challenged to move towards value-based payment. And because of entrenched interests, and that's a whole presentation on that. But district was a 5-year program, incrementally moved. 5 years from now, I don't think we're going to be in a 100% value-based payment world in New York. That maybe put my foot in my mouth. 5 years from now, I'd love to be wrong about that. But we're going to be moving in that direction over. I would say it's over a period of time. But yeah, in the immediate term, I think Emily's right about what's going to happen immediately next. Hopefully, we have a good report to convince somebody to fund the initiative. I mean, that's the idea.
We're getting started.
Well, yeah.
Okay.
When you say we, I mean, yes.
Yes.
I just have a quick one. I'm hearing everybody correctly. I think why is it that we're looking for issues where we can cross-pollinate data? That's just the basic bottom dollar. So I put it in 6 times in 6 different systems. Is that what I'm hearing?
Yes. Okay, great. So I'm going to move through these slides a little more quickly, just so we can get to more
Yeah,
discussion.
it's almost 11:30.
Yeah. So basically, the next section of this is just going through a couple of different other models that exist. I don't want to belabor it too much because I think it seems like everybody sort of understands the different models that are out there. These are the ones that I'm going to talk about a little bit each in this presentation. So I mentioned there's the Robert Wood Johnson's DASH grant program, which is a foundation-funded initiative, clearly, that is really interesting in some of the ways that they are trying to integrate CBOs. It may be one of the most focused on CBO integration. There's DSRIP, there's California's Whole Person Care Program, and then there's 2 others that I'm going to talk about actually on this slide. Alaska's Medicaid waiver and North Carolina's Medicaid waiver that are both really kind of cool. So really quickly, Alaska, very focused on behavioral health and substance use disorders. And in fact, it's almost all focused on that. It's 100% about connecting those with the healthcare system. And as you know, there are a number of social services agencies focused around substance use disorders and for it's various social issues, including family issues focused around substance use disorders. And so there's some really interesting work going on in Alaska around trying to get state assistance for policy development, for trying to not get around, but to build technologies and capabilities for sharing of data that conform with the special rules that protect substance use treatment data, which has its own special restrictions. HIV treatment data also has similar restrictions. And so they're working very, very hard to do that. In fact, they're basically trying to create a statewide approach that's like a behavioral health information exchange. I spoke to somebody in the room here earlier about how there's some effort to do that here as well. So there's some similarities there, but it is very kind of laser focused. As I pointed in earlier slides, it's very laser focused on one issue, but an issue that in Alaska is really prominent right now. The other one that I think is really relevant is North Carolina's Healthy Opportunities pilots, which are their 1115 waiver. I haven't worked on this in North Carolina. I just know from some research what's been going on. But they are really trying to put community-based organizations at the table from the very beginning. The state procured a system that they use to allow to do two things. To sort of be like almost like a yellow pages of all of the community-based organizations in different regions of the state, and then allow you to do a referral basically to those organizations, so that if you're a healthcare provider or another social services provider, you can go in, find an organization, send a referral, basically put some structured information in there about like what type of referral this is, and then you can track the progress of that referral after it's been conducted. So it's what's called a closed loop referral system for both healthcare and medical services. So it's all unified into one system, which is novel. I don't know that I know some communities have tried to do that. I don't know of a state where they've implemented a statewide approach to doing that. So that's one thing that they've done, and then they're encouraging all these different communities, they're sort of like the district PPSs, to collaborate between social services and healthcare. It's all focused on social services and healthcare. They just got started, they just got their award, very recently. So there's not a lot of data coming out of how's it going, but they do have kind of a unique model and approach that we can kind of think about. Also, just really quickly, California Senate Bill 1152 just passed in California is a big deal because it may become model legislation for other states. It basically tells hospitals that they must take into, if somebody is homeless or at risk of homelessness, they must take into account special referral services, discharge planning for them. Basically, they are required by law to make sure that they're connected to a housing services agency and certain social services that individual might need, like food security. So the hospital is actually required to do it, or they can be penalized basically by the state. It's really, it just started in January. It's sort of messy the way that all the hospitals are trying to implement it, but the result is that a lot of hospitals are implementing these systems that are kind of like the referral platform that I was talking about that North Carolina has, but each hospital has one, and they're sort of saying, well, this is our way that we're connecting you to social services agencies. It works well when you've got one big hospital system or set of hospitals serving a community. It doesn't work as well when you've got 5 different hospitals that have 5 different systems, and they're all trying to refer people or do discharge planning with housing agencies, and the housing agencies got all these systems they have to deal with. Which is why I think it's important for community-based organizations to say, in some cases, to the healthcare system, this is the system we're using. It works well for us to do this. You guys need to conform to us as opposed to us to conform to you. But it's very kind of cool that California has decided to legislate this to address a big need, because hospitals were just sending people out the door with nowhere to go. It was a big problem.
I want to add one thing too that I think will be helpful that we have talked about. Part of this is also making sure that when community-based organizations, when HEALI gets to the point where we're engaging together in whatever contracting may or may not ultimately happen, we also are getting paid for the referrals and the services that we're providing. Because what happens often, this was one of the things that came up early on in our conversation, is that referrals are made, but they're not always attached. They don't come with dollars. So we're doing, many of us around this table are small agencies who have seen funding disappear, right? Long Island has lost a lot of its primary sources of private foundation funding over the past several years. So we want to make sure that we advocate for ourselves in that way too, right? So that what we offer as a collective in terms of the data and the care coordination and the services, that we also are appropriately compensated financially for what we do, so that, you know, it's not just here's the referrals, do the work, but there's no compensation attached. So I think that that's really important too, Linda, when you're thinking, you know, higher level about what are we trying to do here. We're trying to create a system that, you know, is responsive to those external, you know, whether it's the healthcare system or whatever, but also that we're appropriately getting compensated for the work that we do. Okay, so try not to get too caught up in that other part, because I watched your face when he was talking about some of that stuff. The medical stuff, that's, you don't have to focus on that yet, right now, at all. So, thank you.
Yeah, in many ways, we're looking at these as sort of to inform, you know, what the assessment will be like, not to say we're going to try to do exactly this or anything like that. There are lessons, you know, sort of to learn from them. So the DASH program that I spoke about briefly is interesting. As I said, it's a foundation-funded initiative, national. It's got a lot of national attention. There are 3 major recipients right now, one in Dallas, 2 in Texas and 1 in Washington State, that are doing different kind of targeted initiatives that involve social services agencies. One of them in Dallas is doing some things that are similar to California's Whole Person Care Program, where they're basically trying to set up a system for the community where everybody can be on one sort of software and collaborate on a care plan for an individual across the community. So you can say like, oh, this person needs housing services, okay, here's the housing information, this person's got uncontrolled diabetes, okay, there's the medical stuff, this person's got behavioral health issues, okay, here it is. And so so you can sort of create a single care team around one software platform. In San Antonio, there's a different effort to try to integrate behavioral health data into their health information exchange, which sounds kind of basic by comparison to some of this other stuff, but in Texas it's actually a big problem, and so they're using the money to solve that. And then in Seattle, they're doing a lot of linkages with housing data around the permanent and supportive housing for individuals, and trying to link that with medical organizations, basically to normalize the data between them. And the goal of these is they're going to create some pretty in-depth reports that they're going to publish on all of these that should be really useful. They're kind of rapid cycle projects by comparison to the 1115 waivers. So we should see some results from these projects a little bit sooner than, say, North Carolina's cool program that they're doing. It's still going to be, 6 years from now before we get to read a report about that. Go ahead.
Sorry, one more, this made me think. It's interesting that all of these initiatives, and I can understand if they're coming a little bit still from the medical standpoint, they're all dealing with the individual.
Yes.
And I think many of us that work more on the community-based organization side don't necessarily use that as the unit of interest. Because you don't usually have one person that's hungry.
Right.
You have a family that's hungry. And you don't usually have one person who's a domestic violence, or you often don't have one person who's a domestic violence victim. You have a family. And so I think as we think about building our system from a community-based organization standpoint, I don't know how the HIPAA and the FERPA and all the privacy things happen with that, but to me, it has to be a family unit.
That's a good point.
That's great. That's great feedback. And I think it reminds me of, in most of the country actually, do you have any housing services organizations here? Yeah, and so you may be aware of this, that the data unit for housing organizations in HUD, housing and urban development regulated systems, is a family, or actually a household is what they call it. It's not necessarily a family. So, but it's a household, and that's been interesting when you try to crosswalk the data with that and healthcare, which is very individual focused, as you said. there are ways to do it. I mean, we're working on it, and it's not impossible at all. But I think it's a really good point that, yeah, healthcare is very focused on the individual, and that we may not want to build systems in this collaborative that are focused on that.
Or a system that can do both, like you
Right.
said, leave it open enough to
do
have
both.
that possibility.
I was just gonna say that because we do mostly work on the individual level,
Okay,
so,
so flexibility,
yeah.
yeah, yeah.
Yeah, but we don't collect data about families. It's really focused on the family. We just
But I was saying
we wouldn't be
someone-
able to report that, is basically
Right,
what
but if
it's
you had a
saying.
young girl who had a housing problem, it wouldn't be just her housing problem, you have to have the.
Right, of course, but I mean, in general, our metrics are
Not
targeted. So it would have to be flexible because we don't have data
Yeah.
on all the families.
Right.
We really focus the data on the girls themselves.
And, you know, and that's really something we talk about that a lot because our funding sources don't really focus on that, but we do work with the whole family.
Right.
Because even, the adult has legal representation for the child, but there's a lot of work that goes with everybody because families are affected. And I think it's no accident that funding sources don't focus on the family because it makes it look like you're doing less work than you're doing, so they can fund you less.
Well, and so that's interesting, and I think that, but something where my mind went, as you were talking about that too, is that wouldn't it be interesting to do, instead of having like HEDIS outcomes metrics for individuals, to have family-based outcomes metrics of some kind? I mean, nothing exists for that I know of, except for some HUD stuff, but around housing. But that would be really interesting, and I think valuable for a community, if you're taking a community-based health approach.
Right.
So really quickly, Medicaid waivers, I talked about these already generally. Overall, just so everybody's aware, the 1115 waivers at their heart allow states to take Medicaid dollars and use them to achieve, basically to deliver for new service and care delivery models under Medicaid. As long as the costs don't increase, that's sort of the goal. Now, it does explain why many times these are healthcare focused programs, why CBOs are not necessarily as central, because they come from Medicaid dollars. They have to change the care delivery system for healthcare. So as you know, in the past, earlier in the presentation, I was talking about, these waiver programs don't necessarily include CBOs, is a shame, and it is, but it's partially by top-down federal design. I mean, that's the way that the system has been implemented in the funding stream. And it's great that states have these dollars to be able to change the healthcare system and to do these things, but it does explain why it's hard to get the federal government to say things like, sure, give Medicaid dollars to non-Medicaid billing organizations. You know, it's tough to get that through. So DSRIP really quickly, and I'm gonna this is one slide on DSRIP that I have, mostly for comparison's sake to whole person care, which I think is a little bit more relevant and I know a lot more about because of the work that I've been doing in California. But you know, so the DSRIP is really focusing on 4 key areas. 2 are process focused and 2 are outcomes focused. So infrastructure development, system redesign for value-based care, subtext, clinical outcome improvements, which is sort of an outcome. These are traditional, for the most part, HEDIS metrics. How are your ER readmission rates, you know, things like that, visits 30 days post to a primary care, post emergency discharge, those kinds of things, which have proven outcomes, you know, for healthcare, for helping folks. But almost all the metrics in DSRIP are those types of medical metrics. There's very few that fall outside of that that are, you know, sort of the kind of pay-for-performance type metrics. And then population-focused improvements, and that's often where the CBOs come into the picture, is around, you know, sort of this population-based improvement sort of outcome for the program. So whole person care is a little bit more, and these are both, so the arrow slide that I just showed you, our graphic, is based on a graphic from the state's application to the federal government for DSRIP. This one is from Whole Person Care in California, so just kind of the conceptualization is a little bit different between the two. So, you know, they're very focused in California on a number of different areas that aren't necessarily as based around sort of metrics, outcome improvements for healthcare. You know, things like sharing of data, coordination of services across sectors, which for them means healthcare, behavioral health, and social services. They see them as kind of three sectors. Patient-centered care, specifically targeting certain populations. In reality, that has turned into targeting homeless populations, which is, you know, worthy and important in California, but that's almost that's the main targeted population besides healthcare. And then kind of community collaborative leadership. These pilots the contracted entity is not a PPS, they're counties. So they're individual California counties. County government in California is a little bit different than here in New York. Counties have a lot of power. I know they do here too, but really in California, counties sometimes actually have more power than the state does, especially around public health. And so the counties are running all the pilots except for one, which is run by the city of Sacramento. Working with the city is very challenging. I work a lot on that pilot. They're really focusing on community coordination with CBOs in a way that's a little bit deeper, I would say, than the district program is here in New York. But like I said before, it's very, very tied to housing services. So I have a few slides on whole person care. So these are some of the types of organizations that are participating in whole person care pilots. They are also focused on implementing infrastructure, and notably, there is a strong focus with the whole person care pilots in implementing what's called a shared care plan, which is similar to the effort that I mentioned in Texas through the DASH program, where everybody in a community, all these types of organizations, collaborate on a single care plan for an individual that will contain information about social services needs, healthcare needs, behavioral healthcare needs. In many cases, they like to share it with law enforcement because, you know, in some cases there's individuals transitioning from jails back into the community, big problem in California, because basically you can be held in a county jail for up to 5 years now in California because of overflowing prisons, which creates a huge, and counties are responsible for the jails, so there's a lot of this jail healthcare kind of connectivity going on.
We have,
that's very interesting.
Excuse me for interrupting, but we have, they're not here today, but we do have a couple of CBOs who help formerly incarcerated folks and currently, and that's a big, and when you talk about social determinants, a lot of the needs around folks coming out of the criminal justice system are not unlike anything else that we've been talking about. So that's another place where we see that overlap. So I think that that's something that, you know, we have to be mindful of too, and also in terms of, you know, another stream of,
Yes.
of funding and of need. So that's something else that we've talked about in this room before.
Yeah. The jail and corrections is often a care delivery black hole. I mean, somebody goes in, they receive care in the system, and then they come out and what happened? You know, and often inside the jail, they don't know what care this person was receiving outside. And as those of you who are involved in behavioral health know, individuals with serious mental illness, it's just a revolving cycle because you get put in jail for a serious mental illness, they don't know you have it, you go back, released back in the community, there's no treatment coordination, it's very unfortunate. And so this is, some of the whole person care pilots are focusing on that as well. But turns out there's a lot of mistrust between healthcare system and social services and the law enforcement community sometimes. And so it can be challenging, and there's a lot of work going into that. I'm sorry, go ahead.
Well, what about the developmental disability community? And
Yeah.
See them represented.
So the whole person care program is adult only.
Well,
And
people with developmental disabilities, adults.
sure, and so I was saying that, so on the juvenile side, there's no new juvenile anything
this is-
involved in the system.
This is just juveniles?
No, this is adult only. And so then I was going to say that is not something that is the focus of any of the pilots that I've been working on, unfortunately, in California, developmental disabilities.
And that's a big piece here in New York. I mean, there's a lot of advocacy around developmental disability
Well,
organizations.
it's also going through the transformation
Mhm.
and as part of the Medicaid transformation. And so there's a lot of similar kinds of things going on with developmental disabilities as with behavioral.
Interesting.
I just wanna, I don't wanna cut us short, but.
No, I'm gonna
I-
skip all the way through. to
Yeah,
the
because
end.
we have 10 minutes till, and I don't wanna hold folks later,
Sure.
and so.
Okay, so I'm gonna not go through as much detail on this. Is it, are you able to share these slides with the?
Yes,
with the
we
group?
will put the slides on the portal, and we'll email them out to
Yeah,
you.
we'll get these sent out.
But maybe I won't email them to you. Maybe I'll make you all good on the portal to see Alex's slides. How about that?
Sure.
Just send an email, let us know when that is.
Okay.
So there's a lot in there about that. So the one other thing, before I go to the project, the only other thing I want to say about whole person care that we can learn from is that, so I was talking about the shared care plan that they all want to implement with each other that kind of contains all these things. There are a lot of different approaches that these communities have taken to implementing a shared care plan. Sometimes they're literally just emailing, or not emailing, but they're basically sending a spreadsheet around that everybody fills out and they're calling the shared care plan. That is not a type of integration that we're looking for here. You know, it's you know, many of the pilots are doing interesting things like building a single system and contracting with social services organizations to say, we will pay you to use this platform, and for every individual whose shared care plan you contribute to, we will, you will get some sort of payment. So there's interesting contracting models that are starting to form in California around collaborating on a single shared care plan. And so, not saying we can get a contracting model in this kind of initial phase, but it's something to think about because there's going to be a lot of not a lot of buzz around that, I think, in the next couple of years. Is there a question I saw?
How are you dealing with the consent for the shared care plan?
Yeah, that's a really hard one in California. So California is a little bit easier than New York in terms of sharing information. So California is what's called an opt-out state, meaning your healthcare data can be shared unless you specifically say, I don't want it to be shared. That's the opposite of New York, which is opt-in state. Behavioral health data, though, is still opt-in. So you've got kind of two different standards. And so what these communities have done is they've created a single, what they're called universal consent forms is often what they're being called, for the community. And they're basically saying for all individuals who are receiving services through the Whole Person Care Program, who are enrolled in the program, they can, you're basically signing a consent that says, I consent to all this, you know, basically having all my stuff shared for the purposes of this program. So the problem with that is that when the program goes away, those consents are no longer valid. So it's only for, it's like a 5-year thing, and it remains to be seen what the transition will be into kind of permanent solution. Also, the state passed a law that said for the purposes of whole person care, some other state laws around data sharing don't apply. They basically voided some of them to make it easier. So there was that too, which was nice of the state to do. But, you know, once again, what happens when the program's over?
Well, where does it fit into the HIPAA care coordination? Because under HIPAA you can do care coordination, so why doesn't it fall into that? Because it's starting from a social determinants organization?
Because in many cases there's an intermediary organization that handles the data before it goes from point to point. So you've got, let's say, Dr. A and Dr. B, they can share with each other under HIPAA care coordination, fine, that's no problem. But Organization C, which is like a health information exchange, or in some cases, some cases actually a community-based organization that's managing the shared care plan, they're either not covered by HIPAA or they're a third party. And so basically sharing with that organization, you have to have agreements in place to allow them to
Yeah,
manage
but once
the
you have the agreement, you have a VAA, and then you don't have that problem.
Right, except for in situations where there's non-HIPAA covered entities involved. Sometimes they need to have a consent or like a release of information. Okay, so I'm going to talk about this project and sort of what we're going to do. We already looked at this slide. These I won't go through in detail. These were the goals that were stated in our scope of work. We talked about them already, basically, that we're going to conduct an assessment to understand where you all are today in terms of your technology approach. Those are things that you're using to coordinate with each other, coordinate internally, to work out with the healthcare system or the state. We want to know what technology you've got today. And we want to know kind of what the problems and good things about those technologies are too. And then we want to also understand what are things that can be done what I can't not use the word use cases. I'm really trying not to. What are some situations where technology solutions could make it easier for you to do what you do today with your the clients you serve and to coordinate with each other as a collaborative? Are there situations where it would be good to be able to share information back and forth because you share clients? Do you think that you share clients but not know because nobody knows who's got what clients? I mean, I think that's probably an issue. But I want to hear that from all of you as opposed to me sort of projecting it into the mix. I know you've had some conversations around this before internally, so I think those are great, and I've been given some of that information by Emily, but we want to find out what you guys want to be doing. So what are you doing today? What technology do you have today? What do you want to be doing? Where are your current pain points, things that are not working well for you? Going to go through that approach. Okay, so overall, this is our data collection approach for the project. We're going to, there's actually one step before this, so I'll go to the next slide. We're going to administer a field survey, so it's going to be an online-based survey that we're going to send all of you. And it's going to be sent out next week, probably on Thursday or Friday. We're shooting for Thursday, but it might end up being Friday that we're going to send you this field survey, and we want it back as soon as possible. We are really, really trying to make it not super long, but it will potentially take 10 minutes to fill out. I'm just going to be
10 minutes.
realistic.
You guys all have 10 minutes.
But we're not trying to do pages and pages and pages of stuff. It's going to be on like probably SurveyMonkey or something like that, so it's not just a giant spreadsheet. And there will be a combination of sort of filling in bubbles and then also some free text fields. Use those free text fields. We're not afraid. We're going to read them. I mean, absolutely, and they're often very helpful. And we're also trying to use good statistical collection methodologies to not try to just give you ideas that you'll select. We want to hear your new and unique ideas that we haven't even thought about yet. So please fill out that survey. After we get the survey back, we're going to conduct key informant interviews. What that means is that we're not going to interview every single organization in the collaborative. We are going to interview as many as we can and try to get some from all different sectors. I know there's sort of a huge number of sectors here, but we're going to try to interview as many as we can and try to get a good collection of information from different sectors. Part of the reason why we can't interview everyone is timing. It's a very tight timeline in this project, as you know. April 30th, we're supposed to have a final report completed. So that's just part of it. I mean, scheduling is going to be a challenge. So we will work with you. If you feel very strongly that you want to be interviewed, I encourage you to contact me, and we can definitely take that into consideration. But we're going to do those key informant interviews. We're going to do an analysis of initial findings that we're going to give to the collaborative staff the end of March. Also, we may do some sort of messaging around some of our initial findings to the group, but we'll have to kind of see about that. But we're going to look at initial findings then. In April, we may go back and gather supplemental data. What that could mean is another short survey, probably not, but it's possible. Might do a few more interviews in April to clear up some information that we've got. We are going to also interview some outside initiatives that bear similarity to this one. Like I said, no one's quite doing this, but I think that there are a number of candidates. We haven't picked who they will be yet, but 4 to 5 outside, maybe not even in New York, sets of collaborative organizations that are working on building IT infrastructure that involve CDOs. We're going to interview them and try to get some good solid data from them as well that will inform our final report. And then we will, during final report due April 30th, with findings and recommendations. We will present, I would like to present that to the group. And then we will also create a sort of RFP, request for procurement document or documents that aren't going to be released at that time because you need implementation dollars to do that, but so that you'll be ready to procure technology solutions that will meet the goals that we've identified in the report should that become a possibility in the future, basically. So just one more slide here. So this is just, I think, the other thing that we're going to do that wasn't on that other slide is that next week on Wednesday, we're going to meet with the steering and IT committees, and I hope have a really robust discussion about what they think should be implemented from an IT standpoint, what some of their ideas are. It's kind of almost like a group interview is the way we're going to treat it in discussion section, because we want to try to do as much data collection as possible on this. And the goal for today, now that we are at time, was to have that discussion here as well, and we ran out of time. So I don't know if you want to close out now, or if we have 5 minutes to just see if anybody
Can we
has
go
any
5
thoughts.
minutes longer, or you guys gotta go?
Yeah, I mean, does anybody have any thoughts about in terms of what I said, technology that would be helpful, painful situations for your organizations that you think technology might be able to address? I mean, we already heard a few of them from some folks, but does anybody else have any ideas about that, or things they wanted to share, ideas knocking around in their head about the project? Go ahead.
So I just wanted to say that this is a huge undertaking, and I applaud, coming up with this idea. So in my organization, we started trying to have different databases which are used by different contracts. So we have guardianship has a different, home care has a different, housing has different. So, and science and everything trying to get together. Technology should be very simple, because most of the time it's the social workers who will be using it. It shouldn't be just another, like a platform which is like with lots of new learning. So something which is simple, having like a dashboard kind of an impact, which could be kind of like, depending on the level of people who needs to see what, it should be very, very clear, and having like a glossary which could translate between different programs, different, funding, requirements have different units definition, even between state and city, the unit definitions are not same. So DIFTA has a different unit definition, NYSOPA has a different unit definition. So you're just having something simple, clear.
Okay, that's great. Go ahead.
Oh, thank you. No, I'm just thinking in terms of a truly, non-Medicaid funded organization who does not get a lot of state money. What we do is really focused on prevention and empowerment. So those are a lot of the, a lot of our metrics are very much at the individual level of the girls that we serve and how many hours we're getting from the program, and we have some understanding information about their families, but really using it as a referral for what issues might come up for them and the families. But I'm just, for example, we're not serving them with any real health, homeless outcomes. So we really are on the prevention side. So just kind of taking that into consideration of like a truly, I don't think we'll ever get Medicaid funding, like where we don't provide actual, I would say, social services. So I just want to kind of, from that lens, think of like how we can actually refer out for our girls on a truly being in more of the prevention empowerment.
But Barbara, I
Maybe
would
you would-
challenge that prevention is an investment in health outcomes. And I think that's where, you know what I mean? So I would argue that you are right there, and you're exactly, you know what I mean? It may not look like that on the outside, but.
Right,
But-
and maybe that's where, I know we had that talk
Right,
originally, because
right.
there's been a lot, when I first knew about this, or even a few years ago, every time I heard about it, I was like, I don't know how much we can really benefit. And I definitely see that now much more, but I guess I'm probably still coming from that feeling of maybe a little bit of an outsider perspective in that way, just because we're not doing case management work. And that's where I just want to, from a non-case management organization, kind of just putting that out.
I think that's why it's so helpful for you to be at the table for these
Yeah.
conversations. And there's somebody else who's not here today who has shared similar concerns. Her program is strictly prevention, but there's a place for that voice. And in this big picture, if we are going, ultimately that would be, I don't know, remember we did that whole magic wand conversation way back a year ago, and the magic wand would be that investments would be in prevention so that we wouldn't be dealing with so many issues later on, right? It's about health, prevention and wellness, so.
Right.
But thank you, I think that that's a really important
Yeah.
comment.
I think I've already got some sort of thoughts in my head around ways that technology might be able to help. I'd love to
Yes.
keep having this conversation, definitely. You had a question?
Yeah, I just wanted to piggyback on the idea of simplicity, because we also have many databases in our agency. Some are imposed by the health home, some we have chosen for other programs. And the staff, you know, with the large caseloads they have, are just totally overwhelmed.
Yeah.
And quite frankly, like, the support staff are also overwhelmed with providing support with the staff to use all those databases. So no matter how great something is, if it's not really simple, and if it's not mandated, it's just not gonna
Mhm.
get used.
That's helpful.
Okay.
Thank you.
I kind of worry about the use of the word technology in both of those sentences, because, you know, rather, if you just take the technology out, it becomes like, what is most important? Because I don't know if we've ever, as a collaborative, come to answer what that is. And if we don't have an answer to that question, we can't build technology to help us.
I think that that's definitely a really, really good point. And so to that end, I think that thank you, good feedback. And I think that in the surveys, we're gonna have to try to think about it from that perspective as well. I mean, unfortunately, we don't have time to do it in as stepwise of a fashion as we might all like to at this stage. But there is a lot in terms of conversations that you've already had, that I have, that have been documented, that I have. And then I will make sure that the data collection and the conversations are focused not just around technology specifically, I mean, that's sort of the end goal, but that we start to talk about use cases. So we put us on hold. They didn't like that question, I guess. Any others? I saw a hand over here.
I don't know if this has been addressed, so I apologize if it has. Is this like have an option of having like a client portal in addition? So as somebody that's utilizing services, I can go on and see
That'd be-
referrals or.
I think that's a good, what I would call use case for the technology. I mean, yeah, is one of the issues that individuals themselves don't have a good access or accounting of the services they're receiving, or they need a mechanism to communicate somehow in a more standardized way than they are right now. And if that's true, then yeah.
That brings up so many other issues.
Sure.
Like what? Because I'm just thinking of
So,
like
you know,
Northwell's
like if-
platform
if
where I'm just viewing.
We could never serve everybody that would benefit from our service. And that, you know, that's our main issue. We just don't have the funding to support that.
Right, and the idea is that if you can't do it, one of
Except
the other
that
agencies.
there is no other agency that does what we do. That has lawyers that provide education advocacy. There aren't that many lawyers around that have that specialty. So that's already something that we are managing.
Right, overload, obviously, right, lack of
Very similar
resources.
to our Helping Grow Long Island. We run into that in some agencies, and we turn it and we say, basically having that access and having the demand actually gives us the advocacy tools
Right.
to say, we need more, this needs to change. There shouldn't be just one agency, or that agency needs more support in order to meet a larger percentage of the population. So you're always going to have that, whether it's in education or housing. I mean, look at the housing sector. But I do think that, I love what you said about empowering that, the family or the individual access. Because I noticed it a little bit in the California plan, that these people were coming up with a shared care plan for the individual. And I was kind of like,
What about the individuals?
what about the individual?
The same thing that we're
How are
going
they
through right now,
included?
right?
Yeah.
Right, and
The
so
state.
how do we empower back that individual?
Yeah.
So this is a really good, I think this was a really good conversation. It's gonna keep going, obviously. I am gonna end it though, because we're at 12:10 and you've taken up a lot of all of your time. Thank you all so much for being here. Alex, thank you.
Sure, yeah.
So